Hi, everyone, and welcome back to Reframe Your Health podcast, where we challenge the norms and rethink what's possible in medicine. Today, we're going to talk about a disease that affects 1 in 10 women, a disease misunderstood. And we have a special guest today. Dr. Yusuf and I are hosting Dr. Gaby, an endometriosis specialist, to talk about endometriosis and how we can look at it from a different perspective. So welcome, Dr. Gaby, on the show. And first, let's define what endometriosis is, and then why is it such a mystery, why it's so misunderstood.
Well, thank you for having me, guys. I'm so happy that finally we can start talking about this important topic, which is, when you see patients in medical practices, it's the dinosaur that nobody heard about it, yet it affects 1 in 10 patients. I believe that we need to do better as a medical community, as doctors, and we need to make a lot of people aware of what is endometriosis. I'm going to go through the short definition because there is a lot of confusion between the endometrium and endometriosis. Endometriosis is cells that resemble the lining of the uterus that are present outside the uterus anywhere in the body. Could be on the bowel, the bladder, the ovaries. It could go outside the pelvis, to the lungs, to the brain. There is not a single organ in the human body where endometriosis was not found. So the major problem that endometriosis truly affects 1 in 10, but also it creates a lot of misdiagnosis, medical gaslighting, where patients don't know what they are. The disease is a multisystemic disease, so it produces a wide variety of symptoms that could be confused with like IBS, PCOS, a lot of misdiagnosis, ruptured ovarian cyst, or maybe a lung disease or a heart disease or anxiety and depression. So that's why if you don't have a specialist that first would listen to your history and then would care about your disease and suggest the right diagnostic therapies or diagnostic modalities, and then do proper surgery to remove the disease, you're going to be one of those patients that spend 10 to 12 years before getting the real diagnosis.
Awesome. I mean, endo itself is not a new disease. It's been around for years and years and years, but I think what we're starting to know, or how we approach it, is kind of new. But historically, we've treated it as just about pain, managing pain, whether with pills and surgery and looking at. But what we really want to know, is there anything beyond just the ovaries? What's the root cause that's beyond just estrogen dominance that could be causing endo or making it worse?
I'm so glad that you asked these questions because everybody believes that estrogen dominance is the cause of endometriosis. This is a very controversial theory because, endometriosis cells produce their own estrogen. They have what we call an aromatase that transform all the testosterone produced by or the male hormone produced by the ovaries or adrenal glands to estrone, which is a weaker form of estrogen that continues to feed those lesions. So in the traditional therapy, go on a birth control pill, let's block your ovary, let's put you in medical menopause by giving you those fancy newer medications. But actually, we're maybe quietening some of the symptoms, but the disease continue to progress because the disease is usually self-managing. So that estrogen dominance is not completely true because some of the patients have estrogen receptors in their lesions, some others have progesterone. That's why different pills, different medication can have different effects on different people.
So what do you think? I'm sure this is a multifactorial disease. So multiple things, maybe some estrogen dominance, maybe some other things that can cause it. But what are things that you think are in the root cause of this disease that we need to tackle? Because, we are from the school of conventional medicine where we give, birth control pills and pain medication to quiet the disease, but we're sometimes making things worse. This is leading to infertility maybe, or to chronic pains that will never go away. So what are things we need to tackle look at, work on in order to, cure this disease or at least control it from its roots?
Yes. So, we have to start thinking in a different way, because endometriosis is a multisystemic disease and requires a multimodal management beyond the ovaries, beyond the pelvis. We need to start thinking about this disease causing immune dysregulation. A lot of things, the root cause of things is inflammation many times, different hormonal imbalances, different impacts on different organs that would lead to worsening of the symptoms, like, for example, the inflammation from endometriosis leading to a small intestinal bacterial overgrowth or to gut dysbiosis, abnormal flora in the gut, and that leads to abnormal flora in the vagina again. And then all these feeds the inflammation and worsen the symptoms of the patients. So by treating indirectly those inflammatory stuff, by treating your immune system, regulating the immune system, I mean, we can change genetics for patients, and genetics play an important role for endometriosis, but at least we have a lot of different and novel therapy and approaches to help treat.
You can change probably the epigenetics.
Yes.
But like, for example, Yusuf is, a PCOS, passionate, and he's a special in PCOS. Do you see PCOS or women with PCOS, or maybe Yusuf can also answer, more patients with PCOS that have endometriosis or vice versa, and are they related?
I mean, Gaby would confirm probably a good chunk of women with PCOS will have endometriosis at the same time. At least 5 to 10, 15% of them might have that. And the difficult part is that a lot of patients with PCOS have pain. But, how do you differentiate whether this pain is coming from just PCOS or is it endo? And then, when you're dealing with one condition, you tend to forget about other conditions. So that's the tricky part. You always have to keep an open mind that both conditions can happen at the same time.
Yes.
But the good thing is that while you're treating one, you can be also, helping treating the other one. Now that leads me to my next question to you, Gaby, is that could be, for patients and for doctors as well. There's a lot of delay in diagnosing endometriosis. I was at fault at sometimes, kind of overlooking some of the symptoms of endo for my patients. But then when I start asking the proper questions, part of the delay, I think, is because historically we relied on, the diagnosis has to be done with looking and doing surgery and laparoscopy. Are there any new techniques, diagnostic tools that are available for doctors and maybe patients should be aware of to bring to their doctors that can help people diagnose endo early on before having pain for years and years and years?
I'm going to tell you something that's really might be funny for a lot of doctors, or maybe sarcastic. The best way to diagnose endometriosis is to listen to your patients. Unfortunately, with the volume of care that everybody practices, where they need to see a lot of patients, they limit the number of questions to patients very minimal. And then that's why a lot of missed things happen. A lot of symptoms are thrown at different systems. So for example, if patients are having diarrhea or looser stools during their period, or even constipation, they blame it to IBS and go see a gastroenterologist. So listening is one of the most amazing tools that we have in our hands to diagnose endometriosis.
I think we become so specialized, subspecialized, that we forget to look at the whole person. And yes, of course, listening, trying to connect the dots, not one thing causing one disease. But yeah, sorry, back to how to diagnose it today.
The other important thing that I want to highlight, we are not treating radiology reports. We are treating a patient. I see many times patients coming with an MRI that is negative. MRI that is negative, that does not rule out endometriosis. It's like many OBGYN fail to diagnose endometriosis. Many radiologists fail to see endometriosis with poor information given to them and no knowledge of the patient, no knowledge of their symptoms. They fail to see endometriosis. So the most important thing that understanding that MRI truly can diagnose 95% of deeply infiltrative endometriosis. Ultrasound as well, the sensitivity. Now we have more trained sonologists and radiologists specialized in endometriosis. They can detect endometriosis, but also negative imaging finding does not rule out endometriosis. Symptoms prevail when it comes. Now, traditionally, laparoscopy, let's do it to diagnose. But even with laparoscopy, I see it often and often. Patient comes in with pictures of laparoscopy where the doctors told them, you don't have endometriosis, where we can see pictures, because endometriosis varies in shape and in visualization, and it's very tricky for the untrained eye. Many times those patients, those doctors don't do endometriosis on a regular basis and tend to miss a lot of those. And that put the patient in a really, really difficult situation because they are still in pain. They're not diagnosed with endometriosis. What's going on with me? That leads to a cascade of...
the question. Sometimes patients do an MRI for back pain and they have, let's say, a herniated disc, but they discover also there's some endometriosis and they have no pain with their periods, no pain during sex. They've had 3 pregnancies. So if you see incidentally what might look like endometriosis, what do you do in those situations? Do you have to treat it?
Pain is not the only symptoms of endometriosis.
Okay,
it could be bloating. It could be gut dysfunction. It could be infertility. A lot of patients find out they have endometriosis because of infertility. Pain, the problem with pain is stigmatized in many cultures. Everybody, if your mom had pain when they had a period, they would say, oh, it's normal to have pain during your period. If you had pain during intercourse, they would tell you, yeah, everybody has pain during intercourse. It's normal because you're a virgin or you just started having sexual intercourse. So there are a lot of things stigmatized that will also create a misunderstanding for the patient. They think this is normal, this is how it should be, and they won't talk about it to their doctors or their providers.
So we did speak about inflammation, and I'm going to go back to it again and again. But a lot of the gut endometriosis axis is gaining a lot of attention. Everybody's now talking about it. Is there a link? What should we do? Should we do further testing? Should that delay surgery? I want to tackle all these 3 at the same time because, we know that dysbiosis or gut imbalance can cause inflammation, and inflammation is one of the bases of endo.
No, I'm going to let you comment on the inflammation, but we know, as a matter of fact, inflammation create crazy symptoms with endometriosis. But what we propose most of the time, because endometriosis lesions or tissue is creating all that severe inflammation. If we're wanting to treat the inflammation, we need to excise completely those lesions. This is the starting point to ensure that we're going to treat all the other things, because endometriosis as a disease can affect multiple organs and multiple systems and create sequelae that will affect those systems. So treating the disease alone without treating the problem created by the disease on other systems would ensure that the symptoms persist. And that's why 30% of patients after proper and optimal endometriosis surgery have persistence of pain. And I want you to talk more about the gut healing and then the inflammation, because this is extremely important.
So they go basically hand in hand, treating the disease with proper excision and obviously trying to heal the entire body from in out as you do that, because one cannot negate the other.
Of course.
Is there anything such as too early of surgery?
This is one of the things that makes me so mad, because when you're telling a patient, oh, it's too early to do surgery, or why do surgery? Your endometriosis is going to come back. These are a lot of things where it shows that sometimes doctors or people don't appreciate the value of the quality of life. If I'm struggling, if I'm in pain, if I'm depressed because of my pain, what do you want me to do? Wait until it's time? What is the proper time? I've done endometriosis surgery on adolescent, 14, 15 years old, and their life is amazing after. And they say like, wow, And their parents are shocked because these young kids, they've been tortured, and even their parents lost confidence in them because you don't have anything. Your scans are negative. But you find that they have endometriosis, and they tell me like, oh, we got our kid back.
Yeah, as if nobody's believing these teenagers, or they're malingering that they have pain.
Yes.
And you talked about depression, and I think chronic pain, chronic inflammation, the gut-brain, connection too, which is all related, can cause these, anxiety, depression, all of that. And speaking of like, don't do surgery now, it's gonna come back. I think also that the first surgery that needs to be done correctly. Yep. And I think this is one of the things I've seen patient coming back and they're having recurrent endometriosis, and let's say they're asking me as a maternal fetal medicine specialist to do their surgery, and I'm not qualified to do it. So where should they go? Because people get confused. They go to their primary care physician, their primary OB, and they're lost. They're stuck there. Where can they find endometriosis specialists? Where are some groups that they can be part of to find these people? Because I know there's very select people in the world that really do the right dissections, and so where to go for help?
So for me, what has been happening, one of the benefits of social media is the awareness that we're raising for endometriosis. Also, the patient support groups now play a role in changing the paradigm of the care for endometriosis. So there are a lot of patients advocacy group that help patient finding specialists. Many times it's important to do research and then understand more about your body. Unfortunately, this is how the healthcare system failed a lot of patients with endometriosis. Now patients needs to take their own care, they advocate for themselves. All what we can do for them is empower them, create awareness campaigns, and then encourage them to go and get into supports group.
But where do they find them? Because there might
there
be misinformation also
yes,
online.
There are a lot of support groups. Nancy's Nooks is one of the most important and influential one. Endoblog Girls on Instagram. You go EndoWatt with our friend Shannon Khan is doing great stuff. Endometriosis Australia, UK Endometriosis. There are a lot of things that help the patient understand better their body and their disease, and then help mend whatever the healthcare system and some of the doctors did to their patients.
Yeah. Gaby, I consider myself lucky that you're around in Miami. If I have somebody with endo, I send them directly to you because I know that you're going to do a proper excision. It's your specialty. And going back to is surgery too early? Is it is there any surgery that's early? I mean, it's part of the fault of the medical training. When we went to training, we were always taught that you keep surgery until the last resort, which is obviously, when we're learning now, it shouldn't be because you're just basically prolonging suffering. You're increasing the risk of complication in that surgery, because when you do it early on and you find certain contained disease and smaller lesions that you can take out, you wait a few years, then you end up having much more advanced disease, higher chance of complications. Now, for those patients who live in areas that are not as lucky as we are, who don't have endo specialists, who don't know what should they do? Should they go to just anybody and do their surgery? Should they travel outside, where they're from to get their surgery done with an endo specialist?
But I cannot tell you that 70% of my patients are out of state, or they drive 6 hours. It's not uncommon because of the limited number of specialists that understand the disease properly and they can manage it surgically, because endometriosis surgery is a spectrum. You could remove a small lesion, and you could do lung and nerve surgery, which is a 4 or 5 hour surgery. So that's why everybody claims I'm a specialist, or I'm an endometriosis specialist. So it's not uncommon for patients to travel. And nowadays, the cutting edge technology is permitting us to do these surgery as ambulatory same day discharge. Most of them, 90% of the patient leave home the same day. So what patients need to find a specialist. A lot of the specialists, they do telehealth. They can take care of them remotely until the surgery. They can educate them about their surgery, the risk of the surgery remotely. But the most important thing is you need to find somebody who listens to you, who understand what's the best thing to do for you, who can educate you and guide you and empower you about your condition. This way you can regain the trust in the medical system, and then even if you need to travel, health is the most valuable thing.
Now, I would want to add something very important, like a big take-home message for people, because when you research endometriosis, you're going to find all gynecologists have endometriosis under, their kind of expertise kind of thing. And this is when, any gynecologist who graduates from residency and applies for privileges, he's going to select endo because he's been trained to do endo. That does not make every gynecologist in the world an endometriosis specialist.
Absolutely.
I am not an endometriosis specialist.
I am not either.
So
I mean,
I also want other gynecologists to get into this, kind of mentality that, if you are not qualified enough to do proper excision, don't do the surgery. Don't look and send the patient elsewhere.
No harm.
exactly.
Do no harm is the most important thing in part of our job. I don't know how to deliver a baby anymore. The last time I delivered a baby was 18 years ago.
Yeah.
I even if my neighbor delivers baby, I don't claim that I deliver babies. And as my ethical obligation, I'm bound to send them. It's beyond having a business or having a surgery, or it's a patient.
Exactly.
Imagine your sister or your mother being treated by somebody. Would you take a flight if the flight attendant said like, oh, greeted you at the door of the flight and he's so nice to you, but he says like, oh, bear with me guys, this is my first flight.
Yeah.
Will you say like, get me off this plane?
Yeah,
And this is what should happen with surgery.
Yeah. And I think also the other big part is preparing the patients for surgery, like optimizing their health. Yusuf was talking about the gut, make sure, they don't have a lot of toxins in their body. So like for any other surgery, because the surgery will be more successful, it will last longer. Of course, the primary surgery done by the correct person, you won't leave any residual endometriosis. I remember during residency, we used to go in, do a laparoscopy, burn those implants, and then we're gone, and that's it. Like, we did not excise them, and now today we know they get excised through the robot. You do all this pelvic dissection, which, if you see videos, I'm sure you've seen his videos, they're scary. You go in and you dissect every single nerve, and I know there's a whole field of neuro or nerve, neuropelvology. So, optimizing patients before their surgery, I think, is also super, super important. Make sure their gut is in good health.
I want to stop you here because I want you to talk, you and Yusuf, about your experiences, because all the patients that I do surgery, I refer them to you guys so you can take care of the post-surgery, post-recovery. I want you to highlight the fact what you do for bowel recovery, the protocols that we instated for bowel recovery, and that helps on the long term for patients. So please talk about this. This is a great opportunity for us.
It starts with the basics, right? Proper nutrition, avoiding ultra-processed food, avoiding processed sugars, eating at the right time. I would say that keeps the dysbiosis at bay, prevent recurrence in the dysbiosis. Putting them on a proper regimen of probiotics, something that would heal the gut microbiome, heal the lining, optimizing their micronutrients, vitamins, encourage them to do proper sleep, because that could obviously optimize their hormonal balance, their cortisol, etc. All of these little things, they don't have to be expensive, they don't have to be crazy things that you have to test and do crazy stuff, but you just basic little stuff that if you add them incrementally, they can do a huge
Yes.
addition.
And then start them before the surgery, because at the end, you're doing surgery, you're excising, but wherever you excise, there's going to be inflammation, normal inflammation. So you want this inflammation to be appropriate, not super inflamed, not under inflamed. So like Yusuf was saying, you try to optimize their gut, their liver, because the liver is big when it comes to cleaning up toxins. You make sure they're plastic free, their personal care products are toxin less as much as possible. So I think all of these are important for any surgery, but especially for endometriosis. I always use the acronym MIND. We try to work on their mental health, because this is affecting their mental health. So giving them positive reinforcement, not giving them antidepressants, because it's going to mess up their microbiome. So we try to encourage them that they will feel better, and put in some mindfulness exercises, yoga, all this. So work on their mind, on their intensity, which I call basically exercise, all types of exercises, nutrition, like Yusuf was saying, and then the D, which is dream, which is sleep, which is I think a tremendous pillar of health that will heal a lot of things. So working on the mind, M-I-N-D, before, and then we continue doing this after. So the process doesn't stop at surgery.
But I've seen a lot of this is for me like very, very crazy when I see some of the stuff that you order to test those inflammation, and how much you can now accurately pinpoint where the problem is in the whole system is for me
those tests are amazing. But like Yusuf was saying, like, we really don't have to spend millions and thousands of dollars on all the tests. You can just pick some of the tests that will give you the most information, right? I mean, or at the end go back to the basics. So you don't have to spend a lot of money.
The thing that I tell everybody is that those additional testing are awesome if you have done everything that is basic already and you've done it right. You've slept okay, you've eaten okay, you've eaten at the right time, you've exercised, you've not smoked, etc., etc., etc. And then you do this additional testing like a GI map, looking at exactly what microbiomes are up or down, which ones you're gonna have to eliminate, which ones you're gonna have to supplement. That's the value of these testing.
Yeah, when you're not, improving. And back to your surgeries. So I know a lot of them are done through robotic surgery. So what's the advantage of robotics? What are you doing inside? I mean, how are you excising those lesions? What are the new techniques, new cameras? I think there's new dyes. There's so many things coming out. Even, I recently heard about the salivary test to diagnose endometriosis. Just, give us some highlights of the new updates in endometriosis world.
As much there are a lot of updates, but if we go back to the endometriosis surgery as a whole, you have to have a team. The surgeon, the endometriosis specialist, is at the center point of the team, but also other multi-specialists could be involved. Now, with the robot, you have more precisions. We can work in really narrow areas. We can see the nerves. The hypogastric nerve is as thin as a hair. And if you damage the hypogastric nerve, it will lead to a lot of bowel and bladder dysfunction for the patients after. So it's important to do nerve-sparing surgery, saving all the nerve without damaging them. Also, we use a lot of the novel dyes, the indocyanine green, that will show us minimal endometriosis in different shapes or forms. Sometimes it's extremely difficult for the naked eye to see it, but with the help of the dye, we can see areas of inflammation, areas of endometriosis. Also, that holistic, more comprehensive approach to endometriosis is teaching us every single day novel things, the value of red light therapy, hyperbaric chambers, peptide, exosomes, all this, because as much as endometriosis it starts with a surgical or proper excision, but also the treatment is more comprehensive and goes into different directions, where every day we're learning something new that will help restoring the quality of life and the health of the patients.
So it's not only a reproductive organ disease.
No,
I think
it's
that's
a
the message also,
multi-systemic disease. And then we should start using this. I've got a patient that had, every time she had a period, she had heart palpitation. She went to EKGs and done. She had pericardial endometriosis.
Oh,
you know, some of the stuff that you hear every day and you see every day is mind-shocking.
Who resected that pericardium?
Me.
Yeah.
So we do a lot of, and that's why the importance of an endometriosis specialist is not for surgery only, but also guiding and creating a roadmap for patients, referring them to specialists like you that we work closely together, referring them to other areas, cognitive behavioral therapy, pain specialists.
What about pelvic therapy? We discussed this in the past.
This
How
is one
important
of the
is
most
pelvic therapy?
important
Yes,
things.
like before or after? When do you send them to pelvic therapists?
Again, it all starts with the main problem, which is the lesions and the disease. When we remove the disease has already, and the inflammation created a major impact on the pelvic floor muscles. Sometimes when you remove the disease, those patients can still feel pain in their pelvis. And then having a specialist, pelvic floor therapist, which we work exclusively with them, every single patient that has surgery, to restore the damage from surgery, the inflammation of surgery, the inflammation that endometriosis created. Sometimes patients have, limp during their periods. They have weakened muscles, piriformis problems, psoas muscle problem. So it's important to rehabilitate them. It's like when you break your leg, you go to the orthopedic, they look at the radiology and they say like, oh wow, your bone healed perfectly. You cannot go out and run a marathon. You need the rehab of all those muscles. And same thing with endometriosis.
Gaby, endo and infertility, that's a big thing. About half of the patients with endometriosis struggle to get pregnant. And the question is, should they do IVF first? Should they do surgery first? Will the surgery impact their ovarian reserve? These are a lot of questions that a lot of doctors struggle with. But I want your input, please. What should they do first?
One of the most important thing is also, like, let me reverse. You said 30 to 50% of endometriosis patients have infertility. 50% or more of unexplained infertility is due to endometriosis. So my sperm is okay, my eggs are okay, I cannot get pregnant, we cannot get pregnant. 50% of the time is endometriosis.
So, sorry, just to interrupt you, unexplained infertility, meaning that a couple is unable to have a baby, and
despite
all the testing
are normal.
Is normal, and these are labeled as unexplained, we don't know what's going on, you go get IVF. I mean, a lot of it is the diagnosis of laziness or not thinking
outside the box, or
enough.
Yeah.
No, this is the thing. Like, unfortunately, a lot of the fertility specialists look at the patient. They can bridge their infertility with IVF. But for me, okay, let's take an endometriosis patient that is struggling daily with her. She got pregnant with IVF. If you do 5, 6, 7, 8 IVF, patients will eventually get pregnant. She got pregnant. Now, if we want to look at the patient from a sole perspective, getting you pregnant, yes, you can get her pregnant with IVF. But how about looking at the patient as a whole? Yeah. Now she delivers, breastfed, no symptoms. Now her symptoms came back in a crazy way, debilitating. Now we have a newborn. Patient is crying on the bathroom floor, not being able to take care of her newborn. She is in severe pain with endometriosis, and she cannot feel the separation to go do surgery from her newborn. Yeah. Now, we ruined her life because she was not counseled or educated properly on the whole picture. She was shown only one side of the picture, getting pregnant. And that's why it's extremely important, the collaboration between an IVF doctor or a reproductive endocrinologist and an endometriosis surgeon. Because age plays a role, where endometriosis is plays a role. We know, as a matter of fact, excision of endometriosis not only improve your chances of spontaneous fertility, but also increase the success with IVF.
But the people are afraid that if they have, let's say, an endometriosis on the ovary, trying to resect it, it's going to remove some good ovarian tissue and lose some ovarian reserve. I think that's what Yusuf was referring to, and we get asked this a lot. So what do you think about this? And does the size of the endometrioma matter?
Usually whenever the patients with endometriosis and a major impact on their fertility, whenever they are able to freeze eggs before surgery, it's better. But many times you have endometriosis on the ovary. Endometriosis continues to damage ovarian tissue. There are controversial reports about the impact of IVF cycles or the high hormonal on the disease itself. It could worsen the disease in a lot of reports depending on the patients and their receptor. So it's tough. You should individualize every patient. You should create a discussion between the fertility specialist and the patient, because if we have the same scenario for a patient who's 42 years old and a patient 25 years old, two different approaches. So
that's where, like you said, a multidisciplinary approach. And I think one myth that I always hear is about go get pregnant, your endo will get better. Correct. Yes, we see sometimes some of the symptoms get better, but endometriosis is not cured by pregnancy. And like you said, sometimes the symptoms would come back. We see patients with pain from the endo if it's been long-standing during pregnancy.
Of course.
And then it can come back even a little bit, with more vengeance, let's say, sometimes. So again, pregnancy is not a cure for endometriosis. Like you said, because a lot of them are struggling to get, pregnant, and, sometimes they get really... and it's tough, they really want a baby, they have endometriosis, they have pain, they don't want to wait to do a surgery, heal from the surgery, so let's, do the shortcut and get the baby, and then we'll deal with the endometriosis. But it might, affect their life also long term.
That's why, it's imperative to have a counseling and education about the whole picture, not just focus on getting the patient pregnant. We have to tell her what happens during their pregnancy, because some of them have horrendous issues during the pregnancy. They have bowel obstruction if they have a large rectovaginal nodule during the pregnancy. They have miscarriages more frequently. They have a lot of placental abnormality or baby growth abnormality just because of the inflammation. There are a lot of things. Probably you could talk about the downside of pregnancy with endometriosis. Most of them won't have any issues, but there are a lot of problems that we need to talk to them about. And we need to talk to them about the aftermath of pregnancy. What are we going to do? Are you cured? No, you're not. Pregnancy might quieten the symptoms, but the disease continue to progress.
Yeah, exactly. Like I said, it might quiet the symptoms, but it will not eliminate them. And the pregnancies itself, have high risk, because a lot of them have adenomyosis, which is endo inside the uterine lining. They have miscarriages. Preterm labor is higher because of the inflammation. Yes. And then, of course, the placental implantation, which is one of the things we fear most, especially if sometimes they've had surgery. Also, it can make it worse. So they really also have to follow up with the right person to follow their pregnancy.
I mean, as you mentioned, they have to be really educated and counseled properly. Because again, he's talking about the obstetrical complications throughout the pregnancy, and then even the delivery itself. There's increased risk of surgical complications when you're doing somebody with endo, increased risk of C-section. So these are things that should be spoken about, whether somebody decides to do surgery before or after getting pregnant.
No, a lot of patients with endometriosis.
The postpartum phase also can be more difficult because of the inflammation and this recurrence that can come back.
And a lot of patients with endometriosis needs to deliver by C-section. They cannot go, even if they're, because like when we remove a large portion of the vagina, the elasticity of the vagina,
they have fibroids sometimes too.
So that's why it's important for patients to understand really well what has been done on them, communicate between the specialist, the obstetrician. We refer a lot of patients to you guys for high-risk pregnancies, or we notify patients that they need to deliver by C-section after endometriosis surgery, even if they've never done that. So it's a constant communication. We have to communicate better around the same patients as different specialists.
Yeah, and I'm sure Yusuf, because he does a lot of deliveries now, like if you're doing a C-section and this patient has endometriosis, you can see it even in the naked eye that this patient has endometriosis. But this is also important to say endometriosis surgery should not be done in a open techniques anymore, because you can see those microscopic things.
Yes.
And you can comment, like when you open up the abdomen, you can know this patient had endometriosis, and she might not know, and she's been suffering all these years. And
that is true. We a lot of times we discover it, right there and then when we're doing a C-section, and there's no knowledge of it. Maybe Labib can pitch in on the next thing that I had in mind, the question. We talk about oxidative stress and stress in general. That can worsen endo, maybe one of the root causes of endo and hormonal imbalance, etc. What can be done supplements-wise to reduce oxidative stress while somebody's waiting for surgery and after surgery?
Yeah, first of all, oxidative stress is a big word. It can come from many causes. It can come from our nutrition, what we are ingesting into our body as far as, toxins, as far as food sensitivities. And then, of course, trying to lower this inflammation through multiple pathways. You have, for example, omega-3s are, potent antioxidants. Of course, the best way is to get them from food, but you have to be careful because a lot of the omega-3 comes from fish, which can have other toxins in them. So you have to kind of balance things and use those as supplements only. Of course, we have more potent one like astaxanthines, we have glutathione, we have like NAC, which is very helpful, especially for the liver to. And now there's a lot of talk about some of the peptides, and you mentioned peptides, especially used in athletes to help with the recovery of joints.
BPM 157.
Yes, exactly. So these probably have not been studied specifically for endometriosis. Hyperbaric oxygen, remember the other day we were talking about it, probably it will lower this inflammation in your body. We're still at maybe the beginning, but I see a lot of modalities that could have red light therapy can be one. And then, of course, concentrating on the sleep, which, Yusuf loves that part. And then, of course, we take sleep for granted, but it's so important for healing. And every day I learn things from Yusuf about how to improve sleep, by changing some things in your house.
Yes,
maybe he can comment on
newer please,
things.
I was shocked when I know.
It is so important, like even yesterday we were talking about things to improve your oxygenation during your sleep. And if you think about it, yes, if you're not breathing well and your oxygen is low, or you have apnea episodes, which I had, for example, your sleep will be disrupted and not healthy. So Yusuf, just comment on few of the things that you discovered.
My sleep isn't perfect, but
nobody's perfect.
I try to get it.
It cannot be perfect.
If I'm on call, I have even if I don't get called at night, I have this anticipatory anxiety
and the potential spans.
But I want you specifically to talk a little bit about melatonin and inflammation, because I think this is the root cause of all the problems with endometriosis.
So melatonin is huge. It's not just about sleep. It's got huge anti-inflammatory properties, right? We want to focus on getting melatonin naturally. So for you to get melatonin naturally, you have to suppress cortisol and stimulate melatonin production. And unfortunately, we live in a hyper-technological world. I keep talking about this all the time. And I'm not perfect. I'm at fault as well. What I try to do every day is I try to watch the sunset with my son. I make it like a daily trip, dad-son trip, that I walk with him. Watch the colors of the sunset because they differ from the colors of the sunlight. That is, the beginning of giving my brain some cues that it starts to kind of wind down. Now we get home. I turn all the regular lights off. I have Hue Philips lights. They all turn red in the evening. My wife makes fun of me, but I do that.
It's romantic.
She's like, we can't see anything anymore. I'm like, well, it's supposed to be like that. I put my phone on, I turn off the blue light on my phone from sunset to sunrise. So that's automatic. I wear blue light blocking glasses. I try to do some, guided imagery, hypnobreathing, but I do a lot of temperature manipulation at night. I drop down the temperature of my house significantly, and I take a warm shower. And then when it's time to bed, I try to warm up my feet and keep the rest of my body a bit cool so that I can sleep. And then the latest hack is it's a device that improves breathing a little bit, especially if you have a deviated septum, etc. It helps you. That's called intake breathing. I'm not gonna promote anybody.
I'm buying it today.
But you can find it anywhere. It's a little device that you put it on your nose with magnets, and it opens up your nostrils like this, and instantly, immediately, you get about 20% extra more air coming in. And it works for me, and I found that I sleep better with that thing on my nose. You get used to it because there's something on your nose constantly, so it takes a couple of days for you to get used to it, but it works.
How about those high-tech stuff that you can put on your ring or as a ring or a bracelet? Do they help make you understand a little bit more about your patterns of sleep?
So they do. I don't use them. I'm a fan. I tell people to use them if they're having trouble sleeping. You will have to see your own character, your own personality, if you're going to be obsessive about something and you're going to be thinking about it. And I also don't like to have anything on my hands, on my wrist, no rings, I wear my watch sometimes just because I want to see who's calling me. But I don't like to sleep with anything on me personally at night. But they do offer you insights. What I would say, if somebody's going to use them at least for a short period of time, 2 or 3 weeks, 1 month, to figure out which patterns or which habits are making you sleep bad.
Yeah. How about like sleeping naked or the quality of clothes that you use for sleep? Because like I've heard a lot of things about sleeping naked will improve your quality of sleep, or simply that.
I mean, obviously it has to work for you. Some people do better if they don't have clothes on them. Some people do worse. It depends on what's.
Yeah, there's a couple of studies actually, and I spoke about this in one of the reels about wearing socks or not wearing socks during sleep. And actually, studies are more pro wearing the socks when you sleep. And although when we were kids, our parents used to take off our, let your feet breathe, but keeping your feet warm because your body temperature drops at night. So if your feet get really cold, you might wake up and you might not feel well, especially if the room is at a certain temperature where you're. But speaking of the wearables are great, but the problem today is they give you so much data that you
don't know what to do with.
Yeah, and now I think AI is going to help us interpret them in a better way, but so much data sometimes is confusing. But short period of time, knowing where the problem is, is it a melatonin problem, is it apnea problem, and then it will help you tailor some of and there are sleep specialists today that will help you. You cannot do this on your own. And speaking of melatonin in pregnancy, for example, when the melatonin gets low, then there's actually a higher risk of preterm labor. Yes. So there are some devices that will help you improve your melatonin or taking melatonin. So it's a great antioxidant too.
Speaking of it, it can be used as a supplement for you to kind of help sleep better and decrease inflammation. Now, of course, you have to do your due diligence, research well, because obviously this is not regulated. The dosages go from 1 milligram to 10, which if you think about it, 10 milligram is like an insane amount compared to what your body is supposed to be doing on its own.
Plus, some of them are, synthetic. You have to be careful. Try to always get melatonin that's, natural plant-based that comes from, certain plants. It's usually probably a bit.
I use the toddler. I use the toddler one.
Yeah, me too.
It seems to work perfect for the kids.
I encourage because, like, for me, sleep is one of the most annoying problems that patients with endometriosis encounter. Yeah. Because adding to the fatigue created by those inflammatory substances, adding to the debilitating pain all day long, they cannot even, like some patients will tell me, I slept for the past 3 months.
It might be one of the tools that you can use to help them fall asleep, to improve their oxidative stress and their inflammation.
Any condition with chronic inflammation will lead to poor sleep. I see it like out of 10 women with PCOS, 9, if not 10, will have poor sleep.
Yes.
Poor sleep. They're tired in the morning, wired at night. Their circadian cycle is completely off. Yeah. So that's the first thing we talk about is learning or relearning how to sleep properly, whether it's, bedtime routine, all these little tricks that I've mentioned, supplementing with magnesium, melatonin, etc., so that, you can reset.
And trying to adjust their hormones, their insulin levels naturally, especially in PCOS. They get these hypoglycemia sometimes at night because of their insulin, high insulin levels. So it's all connected somehow, you know.
No, I'm so
PCOS,
glad we're talking about this.
Pregnancy, everything is, this is...
Because like as an endometriosis specialist, it's true, surgery is the start of, taking away all the problem created. But also there are a lot of alternative therapies that should be incorporated on a daily basis in a comprehensive healing regimen for all the patients with endometriosis.
And this is actually our message for, anytime we have a specialist, we like to look at diseases in a different way, attack them from different perspectives, holistically, functionally, conventionally, surgically. So, this is the goal of the podcast.
For me is, I want you guys, because I know this is your areas of expertise. Can you try to explain to me a little bit how acupuncture is helping decrease inflammation from a scientific way, make it in lay terms so I can understand it as much as the patient can understand it?
I wish I knew. I would tell you, I wish I knew how scientifically it would, but I know it does work.
Yeah. I mean, I
know it does work.
It's like Chinese to us, but no, honestly, they work on many meridians in the body, and I'm sure there are some areas in the body that once you trigger them, they're gonna divert inflammation to a different site. So I think that's how it works. We're not specialized in this, but we looked at the data. Yes, it does help in a lot of diseases, including endometriosis.
And two things, I think these are your area of expertise: the mast cell activation syndrome and the vagus nerve stimulation. I want you to just simplify this.
I'll talk a little bit about the vagus nerve stimulation, which is, it's gained a lot of attention in the biohacking world right now. You see devices everywhere. You don't need a crazy device to stimulate your vagus nerve. It could be as simple as just humming. But just to let people know what it is, a vagus nerve is your nerve that kind of calms you down when you need to calm down. Unfortunately, a lot of times we're living in chronic stress. Stress is good, not chronically. So the way we kind of ease down stress is by stimulating the vagus nerve. There are multiple ways of stimulating it, whether it's humming, putting your face in cold water, some deep breathing, or if you want to use a device, by all means, there are devices that as cheap as a couple of $100 that you can buy them and incorporate them as part of your routine in the afternoon and the evening, put them on, and that would be your meditation where you actually stimulate.
And this will decrease inflammation.
Yeah.
Ultimately, it will, obviously, because you're decreasing cortisol levels.
And your perception of pain. And speaking of mast cells, also mast cells are a type of white cells we have that are usually involved in allergic reactions, and they produce all these cytokines and
histamine.
Yes, and histamine especially. There are data that these can play a big role in many inflammatory diseases, including endometriosis. So sometimes targeting that part, controlling the histamine release, which can cause you flushing and cause inflammation in all of the body, can help. We were talking about toxins before, like mold, which is also can be a cause of mast cell activation that can also worsen symptoms. This is a great topic that I think we tackle from all angles.
We can branch for about that. But let's go back a bit to endometriosis. I want you to give us, 5, 10 weird symptoms that women with endo can have. Weird symptoms, not just pain. And, I want the weird stuff.
As simple as bloating, we talked
Everybody has bloating.
More anxiety. Endometriosis produces a lot of anxiety because if you go back, pain, when we look at a lot of those movies from Vietnam, they use pain to torture prisoners. So imagine a patient being tortured by pain. So that produces a lot of mental health impact, endometriosis. Social isolation is one of the things that is overlooked in endometriosis. You don't feel like going out. You don't feel talking to anybody. You feel like staying in your room. It's like migraine, shutting down the lights. A lot of the inflammatory stuff like, back pain, limping, sciatic nerve could be involved. 20% of back pain originate from the pelvis, where everybody's go look to the chiropractor and then to the orthopedic surgeon or spine surgeon to find out what's their cause of pain. Uneasiness, like you cannot sit down, we call it akathisia in medicine, could be a symptom of endometriosis. So there are a lot of things. The most important thing is endometriosis, because it's a multi-systemic disease. You can shove underneath that diagnosis a lot of the symptoms, and then vice versa. A lot of the symptoms could be blamed by other system rather than endometriosis. So the most important thing is finding somebody who can understand and listen and try to create a connection between your symptoms, give you a proper diagnosis, and at the end, as I mentioned, a lot of symptoms overlap from multiple diseases. So tackling endometriosis primarily, seeing what symptoms remain and tackling them might be the key.
Have endometriosis been reported in non-human animals, like in other?
Yeah, of course.
So which ones?
No. Most of the mammals have endometriosis, like the baboons. Most of the original study, unfortunately, were done on baboons, and then on mice. There are all the studies on guinea pigs, mice. They have endometriosis. So,
since you tackled earlier how before we branched a little bit, but talk about the animals, you started talking about how you would, or envision, or how you would see the approach for treatment of endo. How do you envision it? Because I know it's your passion.
Mm-hmm.
How do you envision the future of endo treatment should be? Just to kind of wrap things up with your vision of how would you want it to be.
It's simplified if we go back to the ethics. Most of the time we look at the innovation and we look at the future, but we forget that there are a lot of tools that we have in our hands that could help ease a lot of stuff. The most important thing is listening to patients, which is prehistorically the base of our medicine. The second thing is treat patients, don't treat labs or imaging. The third thing is get the appropriate training and be ethically bound to refer your patients to the right specialist when they need them, because a happier patients, a healed patients will appreciate you better if you took care of them by referring them rather by not doing the right job for them. And then technology is going to help us to understand more things. Research is going to help us to understand more things, and then implement different strategies or different protocol to heal the disease. So basically, all what I envision for the future is try to implement or understand whatever we know now and how to help us understand these patients and help us improve their quality of life.
Amazing. I mean, thank you, Gaby. This has been super insightful. I wish we could talk, 2 or 3 more hours to go.
I hope you invite me again.
we should, but I really hope everybody enjoys this and that, it's a value for everyone, whether they're patients or friends of patients or doctors. With this, Labib, thank you.
Thank you, everyone. And we'll hope to, see them in future episodes where, we'll be tackling diseases, like we said, from a different perspective, trying to reframe, any health issue. But I think the message also from us, like every episode, ask why and reframe your own health. And thank you so much, and see you next time.
Thank you.